Okay, all right, sounds good. Then I will go ahead and start. Okay, welcome everybody. Just do a thumbs up or a wave or something and make sure you can hear me before I keep going. All right, perfect. All right, so we are going to cover what you should expect from an occupational therapist who might be working with your upper limb loss client. So welcome everybody. A little bit of background about myself. I have worked in outpatient rehabilitation, and then I went to work for Autobach and travel around the world and the country for several years. So this is what my office looked like for about 9 years. I went on to work for Advanced Arm Dynamics, now known as Arm Dynamics, for a couple of years. And then I had kids and took some time off, but they've been around prosthetics since they were infants. I've continued to stay involved, and then in the recent past have started a nonprofit called Enhancing Skills for Life, which supports the Skills for Life bilateral upper limb loss workshops and other mechanisms and programs to get people that are missing both arms or all four limbs to get face to face. And I also see patients and do some consulting work. So today we are going to cover how can you guys best partner with an OT, and what should an OT be doing with my upper limb loss or limb absence client. As you probably are pretty aware, the two most common upper limb amputation causes are trauma and surgery. That's quite different from lower limb, but approximately 75% of all upper limb amputations in adults are caused by trauma, so motor vehicle accident, machinery accidents, gunshot wounds, electrical burns. So why would this matter to occupational therapy, and how is this different from lower limb? Well, it can be kind of a psychosocial aspect that has to be taken into account, because someone wakes up in a recovery room, may not know what happened, so it's a traumatic, shocking, overnight change in life situation. And so typically with lower limb, many times people are aware that they might be getting a limb removed and have planned for that surgery. So psychosocial aspects are quite different when it comes to trauma and upper limb loss rehabilitation. So we have to take that into account during our sessions. So when you utilize an occupational therapist in upper limb loss rehabilitation, what benefit is it to you guys? Why would you want to do it? So I can answer the question for you, but ideally it's the best thing to do for your patient, because they're going to have a better chance of improved outcomes. I can just give you some of my observations over the past 20 years or so. I've traveled quite a bit around the US and the world, and I've taught courses, I've done some problem solving, I've addressed technical assistance, I've treated multi-limb loss clients. And so what I've seen is that OTs are very underutilized or just not involved at all. And that's for various reasons that we'll get into a little bit more detail here shortly. But if the OTs are utilized, then what I've seen is they're typically only involved during and after, once someone gets a prosthesis. And so, why is that a problem? If they're only involved during, after, once someone has already received a prosthesis, you can run into a few problems. If range of motion is an issue, if swelling is an issue, if there's hypersensitivity, if there's scar adhesions. So a lot of those things, if we address them, that then ultimately could impact how a socket fits and how harnessing is in any kind of myoelectric programming, or even the electrode placement. So we might, the person might be really excited to start using their prosthesis on day one, and we come to find out we got to take several steps back before they can actually start wearing something and starting to incorporate it into their daily life. So that's just a little background on why OT should be involved prior to even getting a prosthesis. And so we'll get into pre-prosthetic therapy here in a little bit, but I do want to cover billing when it comes to OT as opposed to prosthetists. So occupational therapists, you are all probably aware of this, bill for CPT codes, and you guys bill for L codes, equipment. And so in a 1 hour outpatient where we might be doing some pre-prosthetic or prosthetic training, we're going to bill for these CPT codes, current procedural terminology codes. And we usually do it, in an hour. That would be 4 units. And just to give you a frame of reference, 4 units, each CPT code has a different reimbursement rate from private insurance, but Medicare kind of averages out for each of the codes. It's about $27, but some are higher, some are lower. Anyway, so over an hour, that might be about $100. But we're going to spend a whole lot more time with the patient one-on-one and doing, again, that pre-prosthetic, preparing the limb to wear a prosthesis, and then once they receive a prosthesis. So here's a sample description of what OTs might use for pre-prosthetic therapy. Neuroeducation, therapeutic exercise, community work integration, self-care management, wound care. So those are just some examples in case you kind of hear a therapist throwing those terms around. Okay, so now, old Ottobock website, but just gives you a good reference of some different codes that might be used for an above elbow. I know this is probably old and outdated, but if you look at this and you take all these L codes into account and then kind of look at what the prices were or are associated with that, you could have a pretty expensive device that just sits in a closet. So I've kind of added up all these numbers for an above elbow, kind of basic, standard tripod grip, old timey hand, and that's about $75,000. I don't want to deliver a state-of-the-art device, or even not state-of-the-art device, and then have it just end up sitting in the closet. So real quick slide just to again show the costs of prosthetic devices. If you guys have
Hey, Shawn?
Yes.
Hold on for just 1 second, because I just got a chat that somebody can't hear you.
Okay.
Rachel, are you able to hear Shawn? Okay. Sorry about that. I didn't mean to
No problem.
Hello.
No problem. Okay, so this slide is just, again, going over generalized costs. If there are updates, please message me and I will update my slide. But generally speaking, your body powered are going to be way less expensive than your myoelectric. And then multi-articulating hands, that's going to go higher, and any kind of cosmetic covering gloves are going to add to the cost as well. So again, just reiterating, it's a expensive piece of equipment that just, it's the more you can utilize an OT to help improve outcomes, the better off you'll be. So it just doesn't get discarded. So why are OTs not utilized by prosthetists? Some common answers I've heard and observations I've seen. I can't find a therapist in my community that is skilled or experienced in this area. I can't find a therapist in my community that's interested in learning. They're scared of the technology, or they don't want to invest the time in something that they won't see very much. And I've trained several OTs how to work with my patients, and then they leave. Contract work, change jobs, stay home after having a child. And I can speak from my OT school. I had a chapter in a textbook, and I had maybe one question on one test. So I did not get much in school in the way of occupational therapy and working with upper limb loss. So most of it is on the job training. And so other reasons OTs are not utilized that I've come across is just knowing what the OT's role is and what they should be doing. So physicians, case managers, nurses, prosthetists may or may not know what an OT is, or if they do know what an OT is, they may not know what they should be doing. So that's kind of what this presentation, the rest of this presentation is about, is just to if you're not getting what you see in this presentation, you need to be asking for it. So what's the process and how do you refer someone to OT? We require a physician's script to see somebody. So all it needs to say is OT, eval, and treat. Simple as that. And then we kind of make our recommendations and submit to insurance and go from there. So you want to find a local facility in your area that has therapists, skilled therapists preferably, or even therapists that are just interested in learning, because there are resources out there to help you, to help that therapist that might not be so secure in their experience or knowledge. There are therapists out there that are willing to assist in the process. Okay, so when it comes to insurance, private insurance and occupational therapy, I'm going to give you some scenarios. So they may be approved a set number of treatments. They might be approved for evaluation only. They might be approved for treatment visits only based on progress. And at the very least, the evaluation is usually approved. So you might only get an hour or 2 hours with them. So you have to know all of this stuff in advance. The OT will then recommend duration and frequency with the goals and submit the information to insurance and then wait for approval. So a scenario that I ran into quite a bit was I'd look on their patient information chart or insurance chart. They were approved for 12 visits for the calendar year. So I needed to determine if their pre-prosthetic issues or their prosthetic training issues were a higher priority, and then distribute those visits accordingly. And I'll kind of go into this a little bit more when we talk about pre-prosthetic, but there's a lot of things you can do pre-prosthetically on a home program basis. Type up something and give that to them to work on a home program basis if it's a pretty straightforward case. So I also discovered through the course of working with patients, State Voc Rehab Commission is a huge help in the case of either no insurance or insurance covers very little, that they can be a huge resource and help when it comes to return to work and any kind of home modifications. So if appropriate, research your State Voc Rehab Commissions. I've also talked to private insurance companies and been able to get a case manager assigned to the patient's case. I know there's a lot of turnover, but if you explain the specialty nature of this area, you can always request it. May not happen, but at least, go ahead and request it. That way you're speaking to the same person every time instead of, different customer service rep each time. So just something to think about. Okay, so we're going to talk about phases of upper limb loss rehabilitation. And then once we get into the prosthetic training, there's going to be other phases. But so try to keep these a little bit straight, or I'll try to keep them a little bit more clear. So ideally, the phases of upper limb loss rehabilitation include pre-prosthetic, preparing the limb to wear a prosthesis. I like another phase that doesn't happen very often, which is called interim or test socket, and then prosthetic training once you have a finalized device. So those last two mirror image each other quite a bit, but just using a test socket versus a finalized device. So what typically, I mentioned at the beginning, typically what happens is that prosthetic training is where OTs are utilized, but we're going to cover the pre-prosthetic piece of it right now. So like I said, we prepare the limb to tolerate prosthesis. We work on range of motion, strengthening, desensitization, scar tissue management, and swelling and shaping. So during this piece, and here's some interesting parts to it. I'll show some pictures in a second of the pre-prosthetic phase, but I first want to mention the golden period, which we've all heard of, that study. And if you haven't, it's from 1984 and people are still referencing it these days, including myself. But the success rate for patients who are fit with a prosthesis within 30 days was 93%. Anyone fit after that 30-day window or golden period was dropped to about 42%. So what I want to show here is something that you could consider if you have a willing and able team approach, is an immediate operative prosthesis idea. But just avert your eyes if kind of gory stuff is not your thing. So this first picture is a little surgical in nature. So just wanting to show an example of someone in the operating room getting their hand removed, and then flaps, sutures, and then after everything's kind of sutured up, then putting some sort of stockinette over it, and then a bivalve cast, hooking up a switch to a myoelectric hand, so that this person then wakes up in the recovery room with a prosthetic arm on. And then here, a few days later in the prosthetist office practicing with their prosthesis. it's not for everybody, just giving you an idea of something to consider if it's at all ever possible. So that person never really has the opportunity to kind of think of themselves as one-handed. And even though it's a mechanical thing that might be attached to their arm, that it's something that, you know, day one they have on. So not for everybody, like I said, but if it's a team that you can work with in this scenario, you might want to consider it. So when it comes to pre-prosthetic intervention, for those that may not have had an IPOP, you want to make sure that you're working with an occupational therapist, like I mentioned before. And so what does an OT evaluation entail, and how does it help you? So it's probably very similar to your evaluation. It's very comprehensive. It's looking at work history, living situation, any other injuries or issues, their past medical history, medications, site of limb loss, dominance, how are they able to complete certain activities of daily living, what assistance do they need, and then what are their goals. So what I've done, what I've been requested from CPs in the past, is to submit my evaluation along with their prosthetic evaluation and recommendations to help insurance approve the prosthesis. So again, that's something that you could request and compile into your arsenal when you are trying to get insurance to approve a prosthesis. Okay, so what end result do occupational therapists want when it comes to pre-prosthetic rehabilitation? Well, we're going to work on, our goals are going to include pre-prosthetically, everything is focused around preparing the limb to wear a prosthesis. So we're going to look at controlling edema. We're going to try to help shape the residual limb if that's not already been addressed by the prosthetist. We're going to help desensitize the limb. We're going to address phantom pain and phantom sensation. We're going to, is there any kind of wound care management that we need to do? Is there any contractures and scar management we need to address? We're going to instruct them in residual limb hygiene. We're going to address range of motion exercises and increase their muscle strength. And on the bottom of this slide, you'll see that most of this, these bullet points can be sent home in a home program format, so you can preserve visits if you need to. And so when you're preparing the limb to wear a prosthesis, why is that so important? If they can't tolerate it because their limb is too sensitive, then you have to address these things before you try to fit them with something. So why do we need to work on these things? It's again to prepare the limb. So for edema control and residual limb shaping, we're going to use drainage techniques, elevation, wrapping, comprehensive bandaging. And then for desensitization techniques, this thing over here is just a fluidotherapy machine, which is like dried corn husks that fly around someone's limb inside of a heated chamber. We do weight bearing, and we rub different textures around the residual limb. So the nerves in someone's limb, as you're aware, are used to traveling to the ends of their fingertips. When we're desensitizing, we're trying to train the nerves to the new set endpoint, wherever that may be. And so here's an example of something we might do with phantom sensation and pain, is a mirror technique. So the affected limb is behind the mirror, and the intact remaining limb, if they're a unilateral limb loss, is in front of the limb. And so they can trick their brain into sending signals and trick their brain into seeing two limbs and seeing signals, sending signals to the affected limb behind the mirror. And that has there's so many different ways to address phantom sensation and pain, along with pharmacological methods, but this is a very interesting one that I've had some good success with. So wound care prior to receiving a prosthesis, making sure there's not going to be any open areas, nothing that needs to be debrided. And then scar management, if they have adherent tissue and you put a prosthesis on it, it's just going to cause it's going to create a friction point and then probably cause skin breakdowns. So we need to make sure that the skin moves with the socket. So we're going to use heat modalities, compression, soft tissue mobilization, and then range of motion. If someone cannot, raise their arm above their head, they're not going to be an optimal and efficient user of a prosthetic device. So we need to work on that prior to them getting a prosthesis. We're also going to work on gradual strengthening, whether it's prone exercises and lifting shoulders, or we're going to use TheraBands for scapular abduction or external rotation. And then for those, I won't get into bilateral because that's a whole other animal, but I'm just going to give you an example here. For bilaterals, we're going to work on core strength and lower limb strength for fall prevention and safety for falls. All right, so continuing on with the pre-prosthetic rehabilitation piece of it, we're going to explore psychosocial issues if needed, as needed. Looking at change in dominance activities, adaptive equipment assessment for if there's something that they want to be independent with prior to getting a prosthesis, what type of equipment might be able to help them with that. And then, if they're going to be getting a myoelectric prosthesis, there are therapists out there that are trained and experienced in helping identify muscle sites and helping train those muscle sites. And then if a patient comes to an OT and hasn't seen a prosthetist yet, that's something that we can say, hey, you know what, let's find three prosthetists in your area, and I'll help arrange those appointments if you need, and I'll attend those with you if you'd like, and so that we can, again, work as a team to improve outcomes. And so just kind of going over some examples of what we just talked about. So here's an example of a psychosocial. We can make referrals if needed, and do peer introductions if needed, in person, Skype, email, support groups, whether it's online or in person. But so addressing the psychosocial aspect of things. And here's some examples of changing in hand dominance. So if someone was right-handed and they've lost their right hand, then we need to work on them being able to sign their name with their left hand, or tie their shoelaces with their left hand, or button their pants, or feed themselves. And I mentioned the adaptive equipment, so I'll kind of go around the circle here, but this is a U-cuff, a universal cuff, and with a utensil in it, so that someone could feed themselves if they didn't, maybe in the example of someone that's with bilateral. And then scoop dishes, so that food doesn't slide off the plate, since they don't have another hand to help keep it in place. This is a one-handed nail clipper, a suction cups on the bottom. Dice them to help hold things still, a plate, a cup, a phone, and then a rocker knife to help cut things, an adapted cutting board, a jar opener, and a suction cup scrub brush that you can put in the sink to help clean your fingernails, or put in the shower so you can scrub different parts of your back or your arm. Okay, so what can you do if you're unable to find an OT right away? You can and should do your residual limb shaping. You can talk to them about desensitization program and give them a home program. At least have the conversation about phantom pain and phantom sensation, and that phantom sensation is completely normal, and it's just being able to feel that missing limb that's no longer there, but phantom pain is something that needs to be addressed. And then instruct them in residual limb hygiene. But OT ideally should address range of motion and strength program, exploring psychosocial issues, wound care, change in dominance, and adaptive equipment. So I do want to mention from the myoelectric evaluation, just the computer-aided tools that are out there, whether it's CoAP system, or Autobox, or B-Bionics. So the tools that are out there or if the therapist is skilled and knowledgeable with these devices, it's going to allow them the ability to determine how many muscles are available for control, the strength and separation of those muscle sites, and the optimal muscle sites that will operate the prosthetic device. And so what I found when I saw that this device was at the prosthetist that I worked with, 20 years ago, I was like, why don't we have that at our facility? Then we could tease out the problems, prior to them even getting a prosthesis. We could train them how to use it prior to them even getting cast. They don't have to wait for a final prosthesis to learn how to use it. They virtually learn how to control the prosthetic device before they're casted. So I really feel like this cuts down on patient frustration, training time, and time spent in therapy. Ultimately, if you have a therapist in your area that's willing to do this prior to fit with the prosthesis for a myoelectric setup. Okay, so here's some videos. Please raise hands or wave or someone yell at me if they do not, if you cannot see them for whatever reason. Let's see. Myo Soft old school showing his open signal and a closed signal. So this is a first day scenario. Maybe later on during the session or the next day, we can look at raise your arm above your head, raise your arm out to, move it out to the side, move it down. What is the socket? So, and maybe helping you guys find the appropriate sites. So here's an example with a test socket on a couple sessions later. And so if they're able to operate this virtual thing within a test socket, great. If there's a lot of effort and struggling and shaking going on, then maybe we need to find some more sites or turn up the intensity, the sensitivity of the electrodes, or within the computer programming. So with the introduction of pattern recognition, a lot of this stuff is kind of depends on which system you have. Pattern recognition is a fabulous option. So this is just the difference is you have multiple electrodes on the forearm and it picks up a pattern instead of one electrode on the extensor side and one electrode on the flexor side, causing it to open or close. So in this scenario, they're picking up a pattern and then they can retrain that pattern every day if they need to. I feel like pattern recognition sometimes takes the OT out of the picture, but in a good way. So it just kind of speeds up the process. All right, so I've mentioned, this interim phase and test socket. I feel it's helpful for everyone. I feel it's helpful to you guys. So if there's problems that you see once the prosthesis has been delivered, then you can address them in the test socket, which is a lot easier than to take apart a finalized prosthesis. It's helpful to the OT because they can take that test socket into therapy and try things out and see how it works in real life scenarios. And then it's helpful to the patient. So it's different, it's the added weight and it's doing it in the different body positions. So they're not just staring at a screen, sitting down, they're able to really test it out in real life situations. So here's just examples of what that may look like. Easier to correct issues in a test socket rather than a finalized device, like I mentioned. And test socket, okay, more test socket pictures. So I'm going to get into what these videos or the images say at the top: controls, training, repetitive drills, ADLs. So I'm just talking about test socket for now. So they're going to cover these things. We're going to cover these things in a bit more depth in a second. Let's say test socket didn't happen and you've delivered this prosthesis and it's fabulous, it's amazing, and the patient they've demonstrated they can open and close the prosthesis and they can rotate the wrist and they can maybe bend and extend an elbow. Is that enough? In my opinion, no. Because what if that's just inadvertent randomness? So they really need the prosthetic training. And so I'm giving you a generalized idea. These are from some chapters in older texts from Diane Atkins and Dr. Meyer on upper limb prosthetic training, just to give you an idea of maybe when someone has an amputation and when they go back to work and how long their rehabilitation training might take. Please don't, use this screen in any kind of insurance denial appeals or anything. It's just an idea for you to know. We used to play a game at my old outpatient facility, kind of like I Can Name That Tune TV show, where I can treat that below elbow amputee in 4 hours. And I can treat that unilateral below knee amputee in 3 hours. So it totally depends on the person. And there's lots of things that go into it: problem solving ability, cognition, age. But I would say that unilateral transradial, you're going to see, quite a bit less time in prosthetic training. Okay, so with prosthetic training, it's a gradual progression of skills, and you're trying as best you can to have them incorporate that prosthesis into their daily life. So some of the things we take into account: is it a new amputee or is it a new prosthesis? Is it body powered or is it electric? Are there any other injuries we need to take into consideration? Any other missing limbs? The level of limb loss, their age, cognition, problem solving ability, activity level, and do they have any adaptive equipment needs prior or even after, now that they've received their prosthesis? So again, what are we trying to accomplish? What do we want to achieve during prosthetic training? So I'm just bullet pointing the goals. We have a quick reference to OT guide, and these kind of bullet points come from those textbooks. But in general, this is not typical, but we do want to make sure we're monitoring the residual limb. Are there any changes in volume and shape? Is there any HO? Is there any bony overgrowth? We want to orient them to their componentry if that has not been covered by the prosthetist. We want to instruct them in a wear schedule, how to take care of their prosthesis, and do a skin check. We want to practice and repeat putting their prosthesis on and taking it off. And then we're going to address controls training, repetitive drills, and bimanual or two-handed functional skill training. That's just basically a fancy way of saying activities of daily living with two hands. So those three is what we're going to talk about in a lot more depth here with the rest of the slides. But so continuation of goals is we're going to continue with muscle training if it's appropriate. We're going to discuss energy conservation education. We're going to address recreational and avocational skills. We are going to discuss return to work and maybe even make a work state evaluation, make those peer introductions if they haven't already been done, continue with psychosocial needs and referrals as needed. And then any other referrals, do they need a work hardening evaluation done? Do they need a driver rehabilitation program? Any other kind of referrals that might need to be done will hopefully help discuss that with the physician and make appropriate referrals if needed. But so we'll talk about the controls training, repetitive drills, and bimanual functional skills here in the upcoming slides. But that's kind of where I think the meat of the OT's skill sets and what they need to spend the most time doing falls. Okay, so in orienting people to componentry, just a review, if it's a shoulder dysartic, then how do they position it? So like that in this scenario, he's using a kitchen sink to hold on while he nudges an unlock switch, and then once he stands up, that arm is in a flexed position so that he can then reach into a overhead cabinet in his house. So then in an elbow situation, how does it lock? How do you internally and externally rotate it? How do you flex and extend it? Is there a lift assist? Automatic forearm balance. How does a wrist rotate? Does it flex and extend also? And how does it open and close? And how do you change out terminal devices for a terminal device? So I'll make sure, please yell at me if this video does not play. This is an example of a bilateral above elbow demonstrating how he rotates his wrist, how he flexes and extends his elbow. Which, if you realize what he's doing, it's showing that if he's got a fork or something, he's able to stab something on a plate and then bring it up to his mouth. And I'll try to fast forward here a second. So he's just locking and unlocking his elbow. Okay, and then opening his terminal device. So in the next request, it's having him flex his 5-function wrist from Texas Assistive Devices. This allows him again to eat or to wipe or do anything midline. So on a bilateral, a 5-function wrist is extremely important. Just my plug there. All right, next slide. We discussed a wearing schedule a few slides back. One of the things I just want to let you know from my vantage point, many times, a patient says, yeah, I heard about a wearing schedule, but I don't know exactly what I'm supposed to be doing. So if you have the ability to type something out and just give it to everybody with something basic as this, please do it. Just don't assume that they're going to remember what they need to do. And it's important that they gradually increase their wear time and tolerance. It's like a new pair of shoes. And if they put it on and wear it for 8 hours the first day, they're going to probably get a blister, and then they won't be able to wear their arm for a day or so. So, and just teaching them that if there's a spot that's red and doesn't go away after 15 minutes, get back in touch with you guys so you can make adjustments. Okay, so moving on to don and doff, putting a prosthesis on and taking it off. Can they do it independently? Do they have a locking pin liner, or do they require pull sleeves to pull into their prosthesis? If they need help but want to do it independently, what equipment might help them? So here's some videos. Apologize, I could not embed videos to save my life. They worked 2 days ago, but I could not figure out how to get them to work yesterday. So I've had to improvise and add these buttons. So locking pin liner that he's able to put on independently, gives him some extra stability. And able to put on. All right, next video. I like this. It's an example of an above elbow using a pull sleeve to get into her prosthesis, to use suction with no harness. And with a weighted end, so it'll guide through the pull hole. And at home, she might do it completely differently. This was just a video we were trying to set up in a workspace, and she was able to adjust by finding a little stool nearby where she would be able to do this by herself. But harnesses, she just hadn't worn a prosthesis in so long because they were always so heavy, and she didn't like harnesses. So this was just an attempt to help her take some of the workforce off of her left arm, since it was starting to become overused. All right, and then I love this video because it just is fabulous. Again, it shows you with motivation and a creative prosthetist what people can accomplish. So this is his setup of how it's kind of almost like a dressing tree, where he's able to then put on the prosthetic arms independently by himself without requiring the use or the help from a caregiver or spouse. So if I have someone coming to me saying they can't put a prosthesis on, this is one of the first videos I try to pull up, saying, well, we'll figure something out. All right. Okay, so the 3 phases, the meaty part of OT. So we're going to talk about controls training, repetitive drills, and biomanual functional skill training. So once they have their prosthesis, these are the 3 main things we want to address. And so when it comes to controls training, well, I'll go back here for a second. So we're making sure that they follow explicit commands and it's not random. For repetitive drills, we want to repeat, repeat, repeat muscle memory. It's important piece of it and shouldn't be skipped. And I'll explain why in a second. And then 2-handed activities for the bimanual functional skill training is what you should do the very last, not the very first. So for OTs, there is a method to this particular sequence of madness. We do not want them to put the prosthesis on the first day and try to feed themselves. It will just frustrate them and get them not motivated to want to try and practice. I have found over the past, oh my gosh, 15, 20 years that the best chance of success for incorporating a prosthesis into your daily life is if it's done in this particular sequence. It gives the OT an opportunity, or the prosthetist an opportunity, to tease out any problem areas instead of guessing what could be the problem. I want to make sure each phase, controls training, I complete with 99 to 100% accuracy. Repetitive drills, 99 to 100% accuracy and consistency. And then I can move on to the next phase. I want to make sure I hit that milestone 9 times out of 10, or 9.9 times out of 10 that they're doing it before we can move on to the next phase. If they can't, there's a problem somewhere. So controls training. It's mirror motion of the therapist. It's saying, open your hand fast, close your hand slow, raise it over your head, pick up something, or sorry, reach towards the floor and open your hand. So basically we'll watch that evolve and see, and that might take 1 minute, might take 10 minutes, but we'll watch that evolve and see how exact they're with the requests of the therapist, but start with the component that's used the most, terminal device, and then move to the other components, and then work on how do they switch between a terminal device and a wrist. If it's a myoelectric or a body powered, how are they going to switch between their elbow and a terminal device if they're above elbow? So we will work on open and close of the terminal device, rotate the wrist, extend the elbow. We're working on direction. We're working on speed. We're working on stopping at a selected point. We're working on switching between components. During this process, we're looking for fatigue and frustration. We want to make sure that they're following the commands and that it's just not randomly opening or rotating when they didn't really want it to. If that's happening, we have to figure out why before we can move on. So we want them to have knowledge of all the components, become proficient, and combine the use of their components, and then make it so at some point it becomes spontaneous for them to use the components. So if they're in 90, 99%, 100% accurate, consistent, efficient, let's move on to repetitive drills. Okay, so here, just an example of a below elbow Greifer wrist rotation. So again, I've already done the piece where I've made sure that they are mimicking the therapist, but now I want to put some objects inside their prosthesis and see how they can manipulate that. This is kind of like a higher level activity. I would just have them grab a cone and move it to the other stack first. And then the next step is when I would try to introduce the wrist rotation. This is just an example of something that you could do or the therapist would do. And again, if they do this over and over and over again, then you can move on to the next step without dropping or crushing anything. And so here's an example of some clothespins. I'm sure you've seen all of this stuff before. And one thing that I'll talk about in a second is that he's rotating his wrist to get it in the Greifer into the appropriate position to pinch the clothespin. Most people on their first day of therapy don't do that. They end up contorting their body instead. So we talk about pre-positioning here in a little bit. But I will say that this I hear the most complaints about because it's pegs or cubes. They're like children games. And so many people say, oh, I don't understand what I'm doing. I'm just picking up blocks. Well, really, if the therapist can explain it to you differently, to the patients differently, that there's a reason behind it. We want to repeat and do these things because if you drop a cone on the floor, it's less frustrating and threatening than a glass of water. So if we feel confident in this, then we can move on to actual tasks like holding a glass of water. So here's just some more examples of pegs and a little ring stand. Again, we don't want to make sure that they are random movements. We want to make sure they control their speed, and we want to make sure that they're thinking about the pre-positioning of where their hand or their terminal device needs to be. So think about if you go pick up a paper towel underneath a rack under a countertop, your hand needs to be supinated. If you pick up a Coke can from your desktop, your hand is in neutral. If you pick up a pen from a table, it's pronated. So in many situations, whether it's below elbow or above elbow, I will see people twist their midline, twist their waist to go do that activity rather than try to rotate the hand or the terminal device into the appropriate position. So it's something that needs to be taught to many people. So in summary, for repetitive drills, we want to make sure there's success with non-threatening or frustrating activities. build comfort through this repetition, motor planning, and the knowledge that the prosthesis is going to do what they want to do when they want to do it. If it doesn't, there's a problem and we need to address it. Okay, so once they've done those 2 steps, now we can move on to the 3rd step, ADLs and two-handed skill training. So I would start off with something that is more, 1 step, 2 step, and gross motor, like folding a towel, putting a pillow in a pillowcase. Later, you could move into making a meal and wrapping a present. So here's just some examples of individuals doing their two-handed tasks. So we've got self-care, we've got vocational things that we're gonna address through these next couple slides. So this is just meal prep when it comes to self-care activities, brushing teeth, wrapping a present or sewing a button on, fixing a tie, using a button hook to fasten buttons on a sleeve, tying shoelaces, clipping nails. This is quite impressive. But incorporating the prosthesis into basic activities of daily living, making it spontaneous. So we're going to go over a few more pictures and slides, but so just some more examples of things that we'd want to address if needed. So childcare, and then in this scenario, practicing on a stuffed animal prior to, practicing on a real child. When it comes to on the job and vocational activities, making sure that we have a complete and thorough job description, making a work site visit with the person, with the patient, and then do they even want to return back to the same job, or are they going back to school? So what is it that we need to address in therapy, and how can we simulate that so it's as close to what they're going to be encountering as possible? And when we also want to address avocational activities. So is it fishing? Is it hunting? We also want to address community reintegration. So being able to go place an order for food at a counter and grab a Coke from a dispense machine and sit down, go to the grocery store and maybe pump some gas. Okay, so in this, what I want to talk about now are just resources that are out there for you. So in general, you want to utilize your manufacturer representatives. They're the ones that are kind of the experts on the technology. So if there's anything you ever need from them, whether it's a loaner or technical assistance, those manufacturer representatives are going to be, extremely helpful. I think that YouTube and web search engines are another great resource. Social media is amazingly helpful in support group aspects, maybe not so much others. Conferences that are out there, whether they're annual or triennial, or if they're virtual. You can also make sure you find the various consultants that are out there, the peer networks, support groups, Amputee Coalition. You want to make sure you find if they need anything with home modifications. For those that you may or may not be aware, there is an international group of OTs trying to help disseminate information about occupational therapy and upper limb loss, and it's a group called HandSmart, and you can just Google that and find out a little bit more information on them. And then let's see, what does this say? I can't see it because something is at the bottom of my screen. Okay, so resources that are specific to training and prosthetics. If you want to take a screenshot of this, you can go Google these things later. But Michelangelo, Be Bionic, I cannot remember which other manufacturers, but they all have training brochures. So you can go out and find information on and pass that on to the occupational therapists if they're not familiar with the technology or how to train. Those are helpful resources. From 6 years ago, there is a PM&R clinics on various chapters when it comes to pre-prosthetic therapy and then prosthetic training. So you can go look up all those different chapters, but PM&R clinics, North America, from I think 2014. There's the Atkins-Meyer Comprehensive Management of the Upper Limb Amputee. There's the Atlas of Limb Prosthetics. May not be chapter 11 anymore. Sorry about that. There are old Autobach online courses from years ago that have some of this OT information that I'm sure they still have on a hidden website somewhere. And then there is a Myo training manual out of the Netherlands that you could probably Google or find. And then make sure to utilize your Academy resources, the State of the Science #9 on outcome measures in upper limb prosthetics, and then the State of the Science #12 on body powered versus Myo. And so Amputee Coalition will have your support groups information that you could find for upper limb. But the last part of the presentation here is a little bit of information on bilateral upper limb loss and quad multi-limb loss and what resources are out there. Because it's more rare and unique than just upper limb loss in general, they're completely dependent for some period of time, and there are entire conferences, like I mentioned previously, that are dedicated to this. So they're called Skills for Life. Our next one is planned for 2021. It may be moving because of COVID, but we're still looking into it. So make sure you go and find the Enhancing Skills for Life website. Oh, here's pictures from the different conferences over the years. But make sure you go find the Enhancing Skills for Life website if you are interested in learning more about the Skills for Life conference organization. And then also within Facebook, Skills for Life has a closed group for people that are missing both arms or all four limbs, where people can go ask questions and get answers. And then similar for quads, they have a closed group on Facebook. So make sure your patients know about it if they are not already aware. Okay, I think that wraps it up. So